Okay, I think we've just hit 1 o'clock. I'm so impressed that so many people have joined us early today, and thanks for giving us your precious time. So we've got a webinar today on NEWS2 and sepsis. My name's Dr. Sarah Morgan. I'm a GP in Camden, and I'm the clinical lead for the NCL-wide training hub. And this really came up as a learning need for people. As many of you are aware, London Ambulance now often require a NEWS2 before you can arrange for a patient to be conveyed to hospital. And so we're very grateful for Nick DATTANI, who's going to be presenting this for us. Can I make sure, I think you are all on mute, but just a reminder to stay on mute, but we do want to make it an interactive session, so please do use the hand function or put a question in the chat, and as we go through, I will be keeping an eye on that for Nick, who'll be going through the slides just to try and make it interactive. Just so you know, also we're recording the session. It's great, we've got numbers rising, but we've got 107 on you on the call so far, and those numbers are going up. But if any of your colleagues want to watch this, there will be a link that will be circulating so that people who can't join us today can still access this training. And so with that, I'd like to hand you over to Nick. And Nick, I'll let you introduce yourself, although I'm sure you're known to many of us.
Thank you, Sarah. It's really nice to be here today, and thanks for inviting me to this presentation. So hopefully all of you know me, but if you don't, I'm Nick DATTANI. I'm a GP in the borough of Barnet and the clinical lead at the CCG. And pre-merger, I used to be the sepsis lead for Barnet, and so I've adapted the presentation historically and made it relevant for today. And so really the background, we all know this already about why we're here, why we're talking about this, and why it's annual training that we should be doing. And that's really to improve outcomes for patient care and be aware of sepsis, and to make sure that we've got the right evidence-based and best practices to prevent and manage sepsis for our patients. And so, as you know, in 2016, NICE published new guidelines for the management of sepsis, and really we're here to talk about those today as well. So why do we need to be aware? Well, I think the key thing here is in red, where actually 44 related deaths in the UK, and how many of those can we prevent actually? And what we're saying really is if sepsis is detected earlier, it could save a number of lives per year. And actually we think about 14,000, and I think that's quite a large number. And therefore we need to be able to make sure we're doing everything possible to be aware of it and demonstrate how we can, manage an acutely unwell or deteriorating patient. Well, why do we need to be aware of it? Well, actually, it can result from any type of infection, and we often think of sepsis being bacterial, like a pneumonia or a UTI, but actually we can see it from lots of things, including fungal infections and viral infections. So what is the absolute definition? The definition is the life-threatening organ dysfunction caused by the dysregulated host response to infection, or a life-threatening condition that arises when the body's response to an infection injures itself, its own tissues or organs. So that's really the broad definition of it. And when we talk about who's at risk of sepsis, I think we all probably know this, but I think we should spell it out. And in the recent COVID times, we've been talking about people that have been shielding. Now, actually, those are really over 70 have been shielding. So actually, I actually question whether, the guidance says those at risk of sepsis are 75, but are we saying in light of COVID, we're saying that age group is 70, quite possibly. Now, of course, we must think about those patients who are immunocompromised, not just on chemotherapy, but we've got people on azathioprine, mercaptopurine, methotrexate, and those kind of drugs. And I think those are really important to be aware of. But really about any recent trauma, surgery, catheters, antibiotic use, or anything like that. And then those patients with chronic disease, we need to be really, really mindful of. And I think the key thing on this slide is that anyone who's healthy can be at risk of sepsis. And I think that's the key thing here to be aware of. It's not just those with chronic disease, diabetes, heart failure, those that we think of. You and I on this call can be at risk of sepsis. And I think that is the key thing to be absolutely aware of. I think we need to be mindful of. So really, I talked about this here. So sepsis is not just that bacterial infection, but it could be that viral or fungal infection. Now, when we say fungus, so actually a fungus can indeed lead to sepsis, and I think we absolutely should really be mindful of that. So we often say, when we say to patients, oh, this is just a fungal infection, but I'm sure all of us know or have seen a patient where they've actually had a fungal infection that's turned into a bacterial infection. Because of it escalating and us maybe not managing that properly. And I think that's really something to be aware of. Now, we've also got to think about people who are post-operative, and I think that's another key thing. People are being discharged right now from hospital, and they're at risk of sepsis, and I think that's a really key thing to be aware of as well. Now, really, when we think about it, what are the symptoms? And I think these can be quite broad, and I'm going to just go to the last point on this slide where it says, I feel like I might die. And I think that's a really key symptom because patients know themselves quite well. And when a patient says, I don't really feel well and I feel really unwell, that is a really important thing for us to be aware of, because actually that can be a key thing there. But actually the other things to be aware of are somebody who's feeling extremely unwell, that temperature as we know about, and previously we talked about temperatures of 38, but what we now are saying is 37.8 and above is a temperature, abnormal temperature. But what's really key is we also recognize a low temperature, so hypothermia, so when the temperature is low, and I think that's a really important thing to be aware of. Someone where they're tachycardic or their respiratory rate is high, or even low in some cases, because that can be a really sign of really severe sepsis when somebody's breathing rate is that low, or somebody who's got dizziness, decreased urine output. And the key thing here on this slide for our older patients in particular is that change in mental state. So, you know, the carer calls us and says, this patient is more confused or disorientated. You know, what springs to mind straight away is, do they have a UTI? Do they have a chest infection? Do they have cellulitis? Because those are the key things. When someone's mental state is altered, it's likely that an infection is going on. And I think that's a really important thing for us to be aware of. So always think, could it be sepsis? Now, when people get sepsis, it can lead to a number of long-term effects on these patients. Now, most people can survive from sepsis, but they can, suffer from significant complications which can impact on their quality of life. Now, often the commonest one is chronic fatigue and muscle pain and weakness. And that can go on for months and actually years in some people. And what we've seen with patients with COVID, for example, that have ended up with COVID pneumonia and sepsis, is they're getting what we're describing right now as long COVID. And the majority of those patients are getting, yes, breathlessness and chest pain, but actually the majority are getting chronic fatigue or post-viral fatigue, and they're getting joint pain and swelling and weakness. And so we could say that these patients may end up with long-term and chronic symptoms like this. So I think it's really key that we pick these patients up on really early. Now, as we know, some people, particularly older patients who have gone through an illness where they've had sepsis and ended up in hospital, they might have lost muscle mass, they might have lost weight from an infection, and that can have long-term impacts on their hair, in particular. And just putting this into context with COVID, some of you may have seen that those who have been quite unwell with COVID have actually had significant hair loss. And I personally have spoken to 4 patients in our practice who have had hair loss subsequent to COVID sepsis. And one of those patients has actually had most of their hair fall out. And I think, these are really detrimental things for patients to experience. And I think we should really be mindful of the long-term effects. Now, in this presentation today, I'm going to assume that everyone can measure respiratory rate, pulse rate, oxygen sats, blood pressure, temperature, all that kind of thing, and know how to assess somebody's conscious level. So I'm going to make that assumption today. Okay. So let's talk about risk factors. factors. Now, we talked about these over 75s and the people that are frail, and we talked about the actual people with chronic diseases. But we often forget about people who have had their spleens out or who've got sickle cell disease. And what we may need to be mindful of is when we're seeing these patients in primary care, is there something that flashes up on our system that says these people have had their spleen out? Often you might see that they're on long-term penicillin, or do we have a major alert on EMIS that says actually this is a patient with sickle cell, be mindful when we see them because they could be having a crisis? Or do we think about people that are on long-term prednisolone or steroids? Now, of course, during COVID, we put them into the high risk group, didn't we? And I think the same thing occurs when that patient phones up, whether it's COVID or not COVID related, about whether they're at risk of sepsis. And I think that's a really key factor to bear in mind. And when we talk about steroids, we're talking about doses of 20 milligrams or more on a current basis, or a long-term lower dose could even be something to be aware of. So, for example, we've got patients with polymyalgia rheumatica (PMR) who are on long-term steroids or other conditions, and they are constantly suppressing themselves to some degree and are at risk. And then the key thing here on the slide is people with catheters. Commonest cause of UTIs and constipation are people with catheters, and those are often people who are frail and vulnerable and often can be housebound, who then dehydrate, and then dehydration prompts them to have urosepsis or other infections and become quite unwell. So these are really key things to be aware of. The group that we often forget about is pregnant patients, and those patients who have given birth or a termination of pregnancy or miscarriage in the last 6 weeks are actually at higher risk. Now, why is that? And that's because they have an impaired immune system because of of what's happened. Gestational diabetes patients, anyone that's had a forceps or a C-section or removal of retained products. These are all women that we need to be also aware of that are commonly missed. Now, we often also need to think about our neonate patients, and actually invasive group B strep B infection in a previous baby is a risk factor. That premature rupture of membranes or the preterm birth following spontaneous labour before 37 weeks. These are all really key risk factors for sepsis, and often we will see these parents and their children after delivery because they'll be discharged back to the GP. And in the current climate of COVID, health visitors might not be doing, going around to patients' houses anymore and doing more virtual checks, and so they can miss these subtle risks and symptoms of patients, and they might end up becoming unwell and then coming onto our system in primary care. It's really to have our antennae up about these patients.
Nick, just before you go on, can we just pick up some of the questions so far?
Sure.
So we've got, how many milligrams of prednisolone is a risk for sepsis?
Absolutely. So we're saying what we're saying is 20 milligrams. Anyone who's on a long-term dose of 20 milligrams and above, or even a short course of 20 milligrams and above, or anyone that's on long-term steroids. Now, long-term steroids is somebody who's on a dose of steroids for over 2 weeks plus, and that can be on any dose. And that's why I say about the PMR patients, they might be on 1 or 2 or 3 or 4 milligrams, but when they're on it for long-term, they are immunocompromised.
And thanks. So the next question from Arshna is about, are patients who have stomas also at higher risk of sepsis? So
anyone who's had any type of intra-abdominal pathology, for them to have that stoma bag, the pathology probably puts them at risk rather than the stoma bag. Now, of course, people can get wound infections around that stoma bag, and that can lead to sepsis, but it's quite an unusual thing given patients are generally who have stoma bags quite used to caring for their stoma bags, and we've got the stoma bag nurses, etc. But having the bag itself is not a risk factor for sepsis.
Okay, and then we had another question. You might want to pick this up later, but it's from my intro, I'm afraid, but about, can we explain why LAS are insisting on using NEWS2 when the RCGP did not endorse the compulsory use of this tool? Do they know better than the RCGP?
Good question, and we can come to that when we come on to NEWS2.
Right. Okay, thanks. We're up to date.
I think what I wanted to cover next was about when we're looking at blood test results, because this is all about us thinking about sepsis and thinking about risk factors. Now, often we can do blood tests on patients when they're not feeling quite well, or we can do routine blood tests on people. And these are key things. There's 3 things I want you to always think about when you look at blood tests, and that's bilirubin, platelets, and creatinine. Now, there's a slight typo there. The platelets should be less than 20. There's a slight typo there. Now, I think what we're saying when we look at platelets, when we think about high platelets, we think about cancers and inflammatory response. So, we think of platelets 400 or 500, we think inflammation. But really low platelets is a worrying symptom. And I think that's a key thing to be mindful of today. Bilirubin is quite non-specific, and obviously we want to make sure that if someone has got a bilirubin of 35 and they haven't got Gilbert syndrome, because that would be a red herring. But say that their bilirubin is always normal, and then they suddenly have a raised bilirubin, we must think about whether they've got an infection. And often that can be a gut infection or something like that. It's normally abdominal pathology generally, but not always. And then creatinine is quite an interesting one, because often we see people with an AKI, acute kidney injury, and actually that can be infection from anywhere. It could be that they've got pancreatitis, it could be that they've got diarrhea and they're dehydrated, it could be that they've got urosepsis, and that's quite a common one. It could even be that it's come from the lungs. And so when we think about AKIs, we actually need to explore every single avenue, because actually creatinine is so non-specific in a rise, it could come from anywhere. But it always needs to think about whether that patient's septic, and generally the rule is if you've got an AKI, they probably need to be admitted to hospital, because actually that AKI can rapidly deteriorate and patients can lead to multi-organ failure, so we need to be really, really mindful of those patients. The next thing I wanted to talk about was children, particularly under 5s. And so this is quite a difficult slide to see sometimes on the screen, so you'll absolutely be able to see the slides afterwards. But what I really wanted to pick up here is when we think about children is categorizing them into green, amber and red. Now, if we talk about the red, for example, if we think about under 5s, now under 5s often can't tell us things. They can't talk and say they don't feel well. But what is absolutely clear is that if we have a child who's under 3 months old and they have a temperature above 38, that is a red flag in itself, and that means that that kid should be assessed. Now, generally, paediatricians are extremely happy to see children under the age of 3 months with a fever, and the guidance in NICE explicitly states that any child under the age of 3 months with a fever should be discussed with a paediatrician, if not seen by a paediatrician. And certainly during this period of COVID, it's definitely something that you would want to speak to the paediatrician on call about, because it could be COVID, it could be something else. Now, of course, it's less likely to be COVID, and it's more likely to be sepsis or infection, because as we know, in that age group, COVID is quite unusual. But anyone also in that age group thinking about rash, neck stiffness, seizures, all need to be seen same day. The other key red flags are in children under 5 generally is a fast respiratory rate, and certainly at 60 they should be blue lighted in. Anyone who's got that sort of, using their accessory muscles or that chest indrawing is a worrying symptom. And the obvious ones are when you can't rouse or awake, get this child to wake up. That is a real worry. Now, we all know what the normal sides are, so I'm not going to go through to the green, but actually in primary care, we're going to probably see amber, intermediate risk patients or children, and I think this is probably the middle box is what we need to really be thinking about in primary care. Now, we should always ask these questions to our parents, and actually a lot of it we can do on video consultations when we're seeing patients right now. So we know as experienced clinicians when we look at a child on video how they're responding. So are they responding to cues? What's their activity like? Are they playing in the background while mum or dad is telling you about them? Actually, these are reassuring things. But actually, if they're quite drowsy, not really doing much, that already makes you worry about that child. And on a video call or a face-to-face, you can see whether there's nasal flaring. You can generally measure a respiratory rate. You can see whether when they strip into their nappy, you can see if they're using accessory muscles, and you can get parents to do a temperature. But what we can't do remotely is a heart rate generally. And as you know, our pulse oximeters don't generally work in under 2s. But you know, I think a lot of parents now, a lot of people have started to get pulse oximeters in because of the COVID, and actually, if their child's older than that, they can put a pulse or a SATS probe on and give us a heart rate or an oxygen saturation. And they're really key things. Now, I've got the heart rates there for the 2 to 5, the 1 to 2, and then the under 1s about when we should be worried about them or not. And one of the other things that we can get parents to do is a capillary refill at home and watch them and observe them on video. I think if we're worried about an amber patient, we should be doing 2 things. We should see that patient in primary care. If they don't have a fever, then they are a cold patient in theory, and we should be bringing them in to examine them. And if they've got a fever, we need to decide, is this appropriate for the hot hub, or do they need to go in and be assessed by a paediatrician? And the other thing is, if we spoke to a child in the morning, do we need to phone that child in the afternoon to check their progress in 4 hours' time? And what kind of safety netting do we need to give to that child? Now, when we're thinking about symptoms and signs in conjunction with fever, these are all the common things that we see in children under 5. So we think about meningococcal disease, the meningitis, the herpes simplex, and the pneumonia. And these are all the symptoms to look at. And the key common ones that we all know and ask about often are neck stiffness, or that bulging fontanelle, or we're thinking about, you know, an increased capillary refill in that child. We generally are not going to see a child with seizures because they're probably going to call an ambulance or go straight to A&E. But we are certainly going to see children with other things going on this slide. Now, the other thing to think about is UTIs in children, because actually these can be quite vague in terms of their presentation, because a child could just come up and say, mum could say, or dad could say, child's vomited a bit and they've got a temperature and they're a bit irritable and haven't fed that well. Well, we've probably heard that most days of the week. And then do we think about UTIs? And often UTIs in children are picked up under 5s, and certainly are picked up quite late, and especially during the time where we're not examining children, we're doing telephone and videos. Is it that you need mum or dad to drop a urine sample off? Do we need to dip it? And that's something we commonly miss. So something to really think about. And then the rare thing of septic arthritis, we don't see it very well, but really it's a really obvious symptom. Any pain or swelling in a joint or limb, you need to think about that straight away. Now, why have I put Kawasaki disease here at the end? Because actually that's a really key thing that's come up during COVID. At the start of it, there was a big press release about this. This fever for 5 days or longer, and sort of that bilateral conjunctival injection without exudate, or that cracking of the lips and that red tongue, or that swelling, or that rash and that lymph nodes really is the key thing here. And we have seen that recently in COVID in children. But again, what we don't want to do is overdiagnose these, because actually the presentation in children was 1 to 3% in kids with fever. It was extremely low, and generally these kids had other chronic diseases, so it's actually quite a rare thing. Now, what's interesting for Kawasaki is that there's no diarrhea mentioned here, although that was brought up in some of the information that was earlier released, but it's been taken back off to say actually they don't think diarrhea was associated with Kawasaki, but diarrhea might have been as a result of infection in general, because as we know, infection in general can cause diarrhea in the systemic upset. So let's talk now about NEWS2, the National Early Warning Score. And there was a question asked about why we're doing NEWS2 score when the RCGP says there's no evidence. And you're quite right, that the RCGP does say that, and they said that in 2016 and 17. But they haven't updated their guidance since then. So I'm not sure what the RCGP position currently is. But what we do know, and I'm just going to go to this slide before I go back, is that NEWS2 has a number of benefits. And actually, it's used widely in care homes, you'll be surprised to know. It's used widely in hospitals, ambulances, And it actually allows us to prioritize and plan, but it also encourages reliable, complete set of observations. Because if I said to you, you said to me, I'm the medical reg on call when you're calling me to refer a patient, and you say, yeah, they don't look right, and I say, what's the NEWS2 score, and you don't know, it's probably because you haven't done, or we haven't known, what's their conscious level, what's their blood pressure, all these kind of things. And actually, we need reliable observations in patients to get the complete picture. And I think that's the key thing here. It's not about where's the evidence in this, but we actually know that if we started to do all of these parameters on patients, actually we're going to have a better picture of that patient, and we're able to make proper informed decisions about that patient. And what's also really beneficial about this score is, let's say that we've got Mrs. Smith. What's her baseline score? So actually, even though we've got a 0 in the middle here, a lot of patients will have a baseline score of 1. And so knowing the NEWS2, you can adjust it, because actually what you're saying is this patient is a 1, but now they're a 5. And they've gone up by 4, not a 5. And actually, that's why it's a really good score, because you can adjust it for those patients and they have that baseline. I think someone might just need to go on mute there. Thank you. So let's talk about the NEWS2 scores. So in white in the middle at 0, these are general, what we call normal acceptable ranges. And I just want to talk about one bit in the middle that often people ask the most questions about, and that is the SpO2 scale 1 and 2. What is the difference? Now, the 2 scale is adjusted for people with significant respiratory conditions who are generally on oxygen. And so for most patients in primary care, unless they're on LTOP, we won't worry about scale 2. And we'll probably have a very handful of patients, if hardly any, who will be using that scale 2 form, will be adjusting. So let's just concentrate mainly on scale 1. And so what we know is that most people, even those with COPD, for example, who are not on LTOP, long-term oxygen, will have a SATs really above 96 and above on air. And again, people say, oh, the blood pressure is quite a big range for normal. Well, actually, obviously, we know a blood pressure above 140, for example, is abnormal, but it's not a marker of sepsis, because what we do know is that if you did my blood pressure right now, it might be 130, but my normal blood pressure is 110, because people have white coat hypertension. Or if I was feeling a little bit under the weather, I might have a raised blood pressure, but it doesn't mean I've got sepsis. So, and that is why it's not a good marker. High blood pressure is not a good marker of sepsis. But what we do know is that temperature, pulse, and oxygen and respiratory rate are excellent markers to indicate whether a patient's going to become septic or is septic. And of course, as we know, confusion, delirium, response to voice and pain are all really, really important things, especially in elderly patients or care home residents. So what does the scores mean, and how do we interpret them? And actually, the 0 to 3 may indicate something is wrong with that patient, not always infection. But for a score of 4 and above, thinking about referral, and 5, you really need to think about this probably is sepsis, or something is really going in, and this patient might need to be referred into hospital. So let's talk about sources of sepsis. Now, we've talked about this briefly, but actually, let's go into the detail about this. So pneumonia, well, actually, we can see all types of pneumonia, and we've seen bacterial pneumonia, viral pneumonia, we've seen COVID pneumonia. And actually, we generally diagnose this on signs and symptoms of respiratory infection. And they have cough, breathing problems, often audible. And actually, when you have a video call with a patient right now, you can actually often hear that audible breathing when we actually are just on a video call with patients, because at the moment we're not auscultating that many chests. And actually just getting someone to sit at the side of their bed and we watching them and listening carefully to that video, we could tell that this person is congested. They're crackly. It's that cough that we recognise is not a standard kind of viral illness. How is their breathing? How is their chest? Are they fatigued? What's their conscious level like? Are they quite exhausted with that breathing and coughing? And I think that actually these are things that we think about. When we think about UTIs, the commonest thing is dysuria and frequency, but actually can a carer or a relative talk to us about offensive or smelly urine, or does that patient have loin pain? Are they having blood? And as we know, about 20% of UTIs are responsible for approximately 20–25% of sepsis, and this is the commonest thing that we see in elderly patients. And particularly housebound patients or people that are dehydrating quite easily. Now, intra-abdominal sepsis, it can be quite non-specific actually, and people might just have fever, but often they don't. They can just be kind of irritable or not wanting to eat or drink much, or have diarrhea. Now, I've put constipation in there because actually it's often a symptom that people miss. So I think constipation is a key thing that we often miss, and I can always never forget the case I had about a year and a half ago, where I had a young patient who came in on Christmas Eve who was constipated and had abdominal pain, and I thought, well, they've got sepsis, they've got appendicitis, because I thought constipation, young person, abdominal pain, red flag. Ended up they had perforated a new tumour that they had no symptoms about, and were septic. But actually, because they're young, they're compensating, and the NEWS2 was 0. But actually, just thinking about sources and the symptoms, constipation is often something we miss. New acute constipation in people who we don't expect it in can be a red flag. And then thinking about our obvious acute abdomen, that kind of rigid, bloated abdomen and guarding of that patient, we know they're going straight in generally. Cellulitis we see quite commonly, and really a key thing about sepsis, and in particular during COVID I've seen a lot of cellulitis, and that is because people have been out in the gardens and the parks and often having more insect bites, or they're brushed against certain plants and they've got shorts on, it's been hot weather, and so we're seeing a lot of cellulitis. And the challenge here is we used to, these people will probably come down to practice and we might mark out their rash or their cellulitis on their skin, but right now we might be just dealing with them virtually. Are we saying to those patients, get a pen and draw around your cellulitis, and if it's going above the line, we're worried about sepsis? And are we doing other things that we would have done pre-COVID? I think these are the key things to be thinking about, because actually we know that cellulitis can rapidly spread and the erythema can get worse, and the skin's always going to be hot. But I think it's really that thing about is antibiotic therapy effective, because a lot of people do need intravenous therapy or a change. And I think what we really need to think about is our diabetic patients, because they are particularly prone to cellulitis, so it's important to check if they've got diabetes. Then we might give dual antibiotic therapy, we might give a longer course, we might keep an eye on them. If they're insulin dependent patients, we might even be more worried about these patients. And meningitis, I'm going to cover really quickly. We all know this is probably a hot topic. We all know about this in and out. Headache, photophobia, vomiting, they're going straight in. And I think that's the key thing there, And then I talked about septic arthritis earlier, so I won't talk about that again. Now, osteomyelitis is a really key thing for us to think about, particularly people who are housebound or wheelchair bound when they develop pressure sores, particularly on their buttocks, for example. These patients could be at risk of osteomyelitis, because what happens is the affected bone will become painful and there'll be erythema, and then they can get deep wounds, and that can go in and become an infection. So we do need to think about that in those patients. And actually, some patients with osteomyelitis, they may have a swinging fever, and so they may actually be afebrile when you speak to them, but just feel a little bit unwell. But then when you leave it and it brews and brews and brews, it can get worse and worse until it's really bad. So really thing to be aware of. Endocarditis, we think, is it completely eradicated, but actually not. But it's something for us to also be aware of. So,
Nick, can I just add to that so we can just take some questions? If anyone has any more questions, please do put them in the chat or put your hand up. So you slightly covered this when you were talking about the cellulitis, but Lucy's asking what happens if antibiotics don't work.
Yeah, really good question. So the question is, often we can wrongly diagnose cellulitis, and I think that's a key thing here. So often people can have phlebitis, or they've got edema in their legs, and because of the swelling, the skin has become red and inflamed, and we can think cellulitis. Now, remember, it's unusual for people to get bilateral cellulitis. Not unheard of, but it's unusual. Generally, we see cellulitis in one leg or one area, not bilaterally or symmetrically. So have we got the right diagnoses? Because often people are throwing antibiotics, and actually the rash or the red leg or the redness is not getting better. And then you need to think, is that patient unwell? Are they systemically unwell? Are they tachycardic? Is it painful? Have they got a fever? Are they feeling systemically unwell? No. So are we treating the wrong thing? The second thing, if it's not getting better, do we, and it's a discharging, skin, do we need to do a swab? Generally, we're not thinking about admitting patients with cellulitis unless not improving, they're systemically unwell, or the area that you've marked out, that area is not, is spreading and getting worse. And then are we using the right antibiotics? So often we can use Fluclox for a Staph aureus, which is the commonest, but often people can have streptococcal infections, and do we need to add in Pen V? And then if that's not working, are we going to go off to a clindamycin, obviously being aware of C. diff? And then patients with penicillin allergy, we might be using clarithromycin. Now, of course, we know with clarithromycin it's not great for cellulitis, and so if people are allergic to penicillin, they may not be treated in a short 1-week course of antibiotics. But really, if they're not improving that and they're systemically unwell, they need to go into hospital.
Sorry, Nick, I think Lucy's question, that was really helpful, but I think her question was actually more generally. It was just, I thought you'd partially answered it when you were talking about cellulitis. So hers was just a general question of what happens if antibiotics don't work. Okay.
Hopefully I covered that in the bit before them.
Okay, Lucy, come back to us if that's still outstanding. I'd like, Lyndon's had his hand raised patiently, and he's also put something in the chat. So Lyndon, do you want to unmute yourself and come in?
Yeah, Nick, thank you. I'm fully in agreement with everything you say about the NEWS2, but I'm really worried that LAS have mandated its use because they can be incredibly pernickety, and there's clearly a large body of evidence that says that NEWS2 isn't validated in general practice population. We're working remotely where we may not always be able to elicit all the signs, and I think with respect, as GPs, there has to be significant push out when LAS start mandating us to do things. Yes, thinking about it is really useful. I have it on my laptop. I use it all the time. But actually, I'm really, really angry, as you might gather, that actually, the BMJ had a leader in October, and when the college considered it, and it's just not been tested on a GP population. So why are NCL, through its clinicians and GPs across London, accepting this mandating from LAS when it's not clinically valid? Yes, encourage us to use it, but I can see someone on the other end telling us we have to do it. And they are not flexible when they mandate things. So yes, encourage it, but mandatory use is simply clinically unacceptable to me. And I don't know what you think about that, or what can be done to have this conversation with LAS, really.
Thanks, Lyndon. Really valid point. So we're not saying that a NEWS2 score is mandatory in NCL, and LAS cannot force you as a clinician to use the NEWS2 score if you can't do it. And there will be times where we've actually spoken to a patient on the phone, and we may have not been able to video them. We may not have any observations on that patient, but it might be that they've said to you, I don't feel well, I'm extremely unwell, or the partner said that to you, and they have that feeling of, I'm going to die. Well, actually, you could quite arguably say, that patient is septic until proven otherwise, and you've got the right to send them into hospital and the right to call AAS. So actually, there's lots of symptoms that suggest sepsis. Forget the NEWS2 score. And that's what I went through at the start of the presentation about, before we even talk about observations clinically about symptoms. And I'm not aware that LAS are mandating us to do it, but they're saying that it's a very useful thing for us to do when referring. So there is no compulsory requirement for us to do it. I hope that answers your question. There's no agreement being made with anyone that mandates it.
Thank you.
I think that's really helpful, Nick, because I think different people are having a bit different experience and sometimes possibly getting a bit of a job's worth operator. But as the Mayor says, just tell them to move on to the next question. So hopefully that will work and you've got enough other intel. Lyndon, you had a comment also to do with Kawasaki. Did you just want to flag that as well?
Yeah, I think the interesting part, and I only say it because a friend of mine is one of the consultants who wrote the paper about the Kawasaki, is that and what wasn't clear from the stuff that came out during the COVID crisis is that the group they're seeing with this sort of Kawasaki-like syndrome with COVID are really a different group. Unlike Kawasaki, which is generally under 5s, Dr. Marshall, who's the expert, was commenting this is largely older children, 11, 12, 13, often of BME backgrounds, often obese, and that when we think about Kawasaki, we shouldn't necessarily be worrying about the younger children who are very unlikely to get it, but this slightly different subset. And her comment particularly was they often present with abdominal pain, a bit like an appendicitis. So I just thought it was worth sharing that knowledge because it's a different group to the Kawasaki that we see with the under 5s, and people just need to bear that in mind. But it is rare, but they really had quite a lot of cases across London, more cases of that than they have of hepatitis B across London in a year. So it's not that uncommon across the whole of the area, but it's a slightly different presentation.
Thank you, Linda. That's really, really helpful. And you're absolutely right. With COVID, they did talk about this kind of, I think 11 was the median age for it, and they said between 10 and 12 it was quite common. And I think they had some 9-year-olds as well, so really, really valid. So were there any other questions, or shall I continue?
No, we're up to date, so press on.
Brilliant.
But let's do post comments if anyone's got any more. Thanks.
So I wanted to talk about a case example, and I'm only going to talk about one case example today because everyone here is generally a clinician, well qualified. So I just want to really highlight about an example. So Mrs. Brown has called the surgery and she's concerned about her husband who has stayed in bed today and is shivery. And he's had treatment for high blood pressure and enlarged prostate, but is normally fit and active. And she's not clear what is going wrong with him and does not feel he's well enough to make it to the surgery. So certainly pre-COVID, this is a classical case that we would get in the morning. Really, really common. Now, actually, there's a big role for our receptionist here. And if we've got any of our admin team joining this call today, it's really about what would you do? Because actually, often you've taken that call as a receptionist. And then how would this request be managed within the practice? Does it go to the duty doctor? Does it go to an on-call? Because actually, this patient or the patient's wife is asking for a visit, probably. Now, are there any red flags that might be asked? And are our receptionists qualified to ask those questions, or do we have they been given some care navigation training? And is there more that might influence the decision as to whether you're going to or when you're going to do a home visit on this patient? And these are all key things about when we think about training reception team in the practice about what to do, because actually you might say to reception, this patient's got a fever. And they're in bed all day when they're normally out and about, and this isn't a housebound patient and they can't now come to the surgery, they feel so unwell. Should they be knocking on your door, ringing you in that consultation room, sending you a screen message and saying, actually, Mr. Brown is really not well, and probably out of the 10 routine patients on your list, he probably needs to be called next. And then thinking about whether you decide to visit this patient. Now, of course, in COVID times, he's got a fever, so you might choose not to. But certainly pre-COVID and when COVID settled down, this is a patient we're probably going to visit. Now, thinking about them, when you visit Mr. Brown, he struggles to give you the history himself, and you determine that he's been feverish for a day and has some difficulty passing urine. What would help you determine really this is possible sepsis or a simple UTI? And I think that's the key thing here. How do we know? Now, when you do some observations and you look at him, you think actually his breathing rate's a bit up at 22, and his temperature is only mildly elevated, 38.1, He's got a pulse rate of 104. Now, what we could say already here that there's some abnormal symptoms there. So what are you going to do with Mr. Brown? Now, you do some more observations, and the SATs are 96, the blood pressure is 110, but his normal blood pressure is 140, and he feels pretty awful. So actually you decide to call an ambulance. And then thinking about what Lyndon said, what are we going to say to the ambulance crew? Now, actually, if we did a NEWS2 score on him, actually we're getting some real readings here, because we've already got his respiratory rate, we've got his SATs at, we've got, the fact that he's got a pulse rate that's elevated and a temperature. So actually, it's quite helpful there for us to make a decision. Now, why do we say that this is quite useful? Because actually, remember in our practices, we've got different types of clinicians. We might have a clinical pharmacist speaking to this patient. We might be a nurse speaking to this patient. It could be an advanced nurse practitioner. It could be a FY2 trainee doctor. It could be a registrar. It could be a really senior GP. And I think when we've got different varying levels of the clinical experience, by actually having a NEWS2 score puts this patient into context and therefore allows us to make proper clinical decisions, because actually what you can see here is that this patient has scored highly on the NEWS2, and so actually you can got a clear-cut decision about what you would do. And I think that's really why NEWS2 is a really good way of managing patients. So that's the example I wanted to give you. So the other thing is about when we talking to patients about sepsis and we're worried that somebody's got an infection but they're not quite septic, but we think that they might become unwell. Are we following them up with a safety netting? Often it's quite good to give safety netting to people via AccuRx, and I've certainly been doing that recently. We've been sending text messages to people to say, nice to speak to you today. If you feel more unwell, this is what you should do. But actually, should we be linking them to the NHS website? So that they're aware of what features to look for, what would be defined as becoming septic. And I think that's a key thing to think about in our practices for when we're safety netting. Before we finish, we've got about 10 minutes, and I just wanted to talk about what our CQC requirements are. And this is quite a busy slide, so you're not going to take this all in, but certainly you can look at it later on. But it's about everyone in the practice getting training, not only on sepsis, but whether you want to train on NEWS2 or not, I think it's a good thing. And about really empowering our reception team to recognise what doesn't sound right and raising concerns to clinicians or the duty doctor. And then the triage process designed to include identifying and rapidly responding. So actually, I'm going to call this patient next rather than the 10 routine was the example I used earlier. And then when we bring patients into the practice, because we are bringing patients in at the moment, and we might triage them and just not quite have a handle on them and bring them down, are we doing the right things? So temperature, pulse oximeter, blood pressure. And then to think about what CQC have said is that actually this year flu vaccinations are really important, particularly for those risk patients, and that's what CQC have said we should be thinking about. And then the other thing I mentioned earlier was safety netting information, how we do that, and what tools we use to then sort of using sepsis assessments and audit tools within our practice, and then learning from events in the practice as well, and discussing them during practice meetings is also now mandated, so that we should be discussing significant events or interesting clinical cases in practice meetings. And then finally in the practice is to make sure that really important right now during COVID is that we ourselves have hand hygiene measures in place, and that all of our staff are having flu vaccines every year. So before I finish and we go on to any other questions, I wanted to talk about top ticks for primary care. And there should really be a senior member of the practice team, either clinical or non-clinical, who's got who is the sepsis lead for the practice. And making sure that everyone is having their learning up to date, and there are clear and appropriate infection control messages which are visible in practices. And we've got available to all staff different ways of safety netting people, whether we're doing that via AccuRx, whether we're giving leaflets out for when we're seeing face-to-face patients, and really having somebody there to audit our prescribing, to safeguard against resistance as well. We're not using lots of multi-drug resistant drugs like Augmentin or ciprofloxacin or Cefalexin. We're using antibiotics appropriately. I think these are all key things here in practices when we're thinking about sepsis as well. And then really improving outcomes in our practice. Well, we know that actually luck is not an outcome. Actually, we can recognise and manage sepsis. It leads to a better outcome. And we as GPs have a really key part to play in this, because we're often the first people to see patients. And that's why we need to recognise that life-threatening infection. And we're not always going to get it right, and that's okay. But it's then about learning from that learning from that episode, and then changing the way we work. And then the really key thing here is communicating with colleagues and safety netting. Not just to say come back if it gets worse. Come back if what gets worse. What are the things patients are looking for? So, for example, with the UTI, if they start getting abdominal pain, they start passing blood, or they get a fever, or they're vomiting, or they're not able to drink. Those are the types of things that you're going to give real clear instructions and advice to patients when it's not just being non-specific. And I think they're the key messages I wanted to highlight today. So I think that's the end of my presentation today. It's about 50 minutes long, and I'm here for any questions.
Thanks, Nick. That was really useful, and thanks very much for putting that together for us. So Milen has shared in the chat a quick blog link which talked about NEWS, and the conclusion being that in the meantime it can be used to help communication with ambulance crew and secondary care, but should not replace clinical decision making. So thanks for sharing that link. Vidya has also posted in the chat that the NEWS score assessment is fine with young patients, but with elderly patients they don't spike temp or have abnormal blood tests most of the time because their physiological reserves are down. So we do need to look at other parameters, i.e. shifts from the baseline, which I think you also mentioned. And the concern is that they found that LAS was using numbers only and not necessarily other collateral information needed for the sepsis assessment. So thanks for sharing that comment. Then someone else also agreed with that comment, but asked, is there a new system for elderly, frail and care home patients?
Thanks. I think a really, really good question. So for care home patients, we still use we also use in advocating the NEWS2 score, but they've got some slightly different parameters that we talked about. And a lot of those are about changing behaviour or mental state. And that drowsy patient or the patient that's not eating and drinking. So we use those kind of softer signs and symptoms for people that might not be clinically trained in the same way as us. But I think it was all really valid points. And ultimately, the whole point of us not being a robot and doing just a NEWS2 score and saying pathway A, pathway B, is that we use our clinical judgment and we look out for those, those subtle signs, or when we, as I said earlier, if I put an unwell child on a video and a well child, you will be able to tell me that that child is really unwell or not, generally just by looking at them from your clinical experience and judgment as experienced GPs or pharmacists or nurses or, other clinicians. So, and I think that's really key, that it's not just about NEWS2, it's about using that clinical judgment and that knowledge and that experience that we've built up.
Thanks. Mayor's asked a question about, is there progress on near patient testing of CRP or lactate to help manage patients in the community and care homes?
Yeah, really good, isn't it? So near point testing of CRP came up a lot, and it's certainly being used widely across Europe. I'm not aware that it's come to the UK. So you're getting an awful lot of thanks in the chat of people finding it really helpful and thanking you for your useful presentation. I think, as Sadat's already put in there, if anyone wants a copy of the slides, do leave your
your details or email on the link that he provided. But thanks very much, Nick. That was really useful, and this will be recorded so people can come back to it if they want to watch it again or use it in their induction programs with new colleagues starting, or for those colleagues who are busy doing the coalface work currently. Thanks very much.
Thank you, everyone. Have a nice afternoon.